I think we can probably get started. So thank you guys, everyone, for joining again this morning. We have quite a cool presentation this morning from a presenter called Luke. I've known Luke for quite a while, and he's sort of transitioned between medical, clinical, and business spaces. And he's going to just take us through some thoughts and some ideas from his side as to what that transition might look like and what opportunities there are that are available to people in the medical space. Just some super quick ground rules. We would very much like you to keep your microphone muted and your camera off. This is designed to be a safe space for everyone to share ideas, perspectives, and thought processes. And it's really a judgment-free space. We'd very much like you to please click on the link or scan the QR code with your phone, and we'll share this again a little bit later to figure out where the app is, and then you'll need to log your attendance at this meeting using the app. If it doesn't come through the app, it's not logged, so please don't put your details in any of the chats. And then just lastly, you will need the special code. So at some point in the presentation, the special code will be shared. That means you need to listen to the whole presentation and you need to pay attention to the whole presentation. So I'm going to hand over to Luke. Luke, good morning.
Hi, morning, Caleb. Thanks for giving me the opportunity to meet with you guys and speak to you guys this morning. And it's a very interesting topic that you've asked to present in a very interesting space which we are in, which is emergency medicine. So I'm just going to do a quick screen share for my presentation, and then we can be on our way. Also, can you guys see me? Thumbs up if you can see me.
Yes, we can see you, Luke.
Happiness. Okay. Then tell me, can you see the presentation on the screen? Right, thousands of thumbs. That's never a bad thing. Okay. So, like Caleb said, we know each other for quite some time. So I first met Caleb when I moved into the private emergency medicine space nearly a decade ago. And when I entered that space, it was with ER Consulting, and I then ventured on to go and take over the management of certain emergency units. One was Life St. George's in Port Elizabeth. Another was Life Kingsbury in Cape Town. From there, I transitioned into the clinical manager role at the company, and then took another leap and crossed into the health tech space, and most recently was the chief medical officer at Kilo Medical. So I was in an executive position at Kilo Medical, overseeing mainly the clinical guidelines and processes and even the operations. And now I find myself in a very interesting space, and that is as the founder and CEO of my own company, one of my companies, which is a consultancy called Modicum Consulting. Let's move on. So when Caleb reached out to me, Caleb wanted me to, like you said, speak about how the transition process worked for me. So essentially, I went from this, which is emergency medicine, to this, which is corporate, or this, which is the clinical space, to this, which is the business space, and so on and so forth. I mean, I think the best comparison is how did I move from emergency medicine clinical to general medicine virtual or digital. But another way to look at it is how did I go from bare below elbows to blue suits and cufflinks? And that's kind of what we're going to be speaking about today. So a few of the topics that we'll be speaking about will be, I'll do a definition of what's a clinician. Also speak about evidence-based attrition. I mean, the reason why we're all sitting on this meeting is we want to practice evidence-based medicine. And are clinicians actually leaving based on evidence-based attrition? So where are they going? How do they leave? Should you do it? And then some open and frank discussion. So I want to use this presentation more for context setting for the discussion. We've got quite a bit of time that we can utilize. So I don't want it to be taken up by slides and blab on my side, but to have it to be a very engaging session for everyone. I mean, there's over 100 of us, well, now over 200 of us on this meeting. So it can be a nice robust discussion as well. And I would imagine for some, if not quite a few, this is an opportunity where you can engage with someone who's been in all of these spaces and can give insight, which you might not necessarily get. So please feel free to ask questions when we get to the open and frank discussion. So, definition clinician. Well, so I first wanted to look around, and we'll start with Google to find what is the definition of a clinician actually. And I didn't quite like this one because it isolates it to just a doctor. So this definition on Google says a doctor having direct contact with patients, rather than being involved with theoretical or laboratory studies. I find the latter part of that definition more important. And if you look at the trend of its usage, definitely saw a peak up until 2019, so pre-COVID times. Then I looked at another definition, which was a little bit more inclusive. A person qualified in the clinical practice of medicine, psychiatry, or psychology. Didn't quite touch all sides for me, so I was looking a bit deeper. Then good old faithful Wikipedia pulled through and listed everyone who's probably on this call. But I think the most important people who are listed in this are those who we see in the emergency space and are relevant to this discussion, which should be clinical associates, paramedics, nurses, and even us lowly doctors that feature, every now and again. But we can't forget that our allied health professionals also fit the definition of a clinician. So why am I defining this? I'm defining this because we need to know what is a clinician to see who is actually leaving practice. Physios, pharmacists, and everyone else are also leaving. And why is that important? So I'm going to plant that seed before we move on. So looking at evidence-based attrition, I thought, okay, let's look at different layers of research. Let's start with or different layers of study and their sling. So I started with a research letter. So this can quantifies like a letter to the editor or something like that in a journal. And as you can see, this one is in the American College of Emergency Physicians, and I quite like this one because in 1991, they published the 10 Commandments of Emergency Medicine, which I quite like and something that I use when I practice. But if you look at the heading of this article, it's attrition from the US emergency medicine workforce. And so in my mind, that means everyone, pre-hospital and in hospital, during early stages of COVID-19 pandemic. So that tells us another thing. So the early stages of the pandemic. So that's like light at the beginning when things was just lamping up. So maybe not at the most hectic part, but at quite a hectic part. I think we all have very cold memories and also some very warm memories of that period. But I want you to remember those when we go through these different points in this process. And you can see that the guys who wrote this article had both medical and then also business qualifications. So there's even an MBA chucked in the mix over here. There's also some science with an MSc, but there's a mix of clinicians or mix of researchers in this article. So I know how we are as clinicians in the emergency medicine space. This probably looks like a long, blurby ABG, and so I'm going to take it straight to the point where you're looking to how dead is your patient, and that's the lactate. And the lactate in this case is 5.3 to 5.7% of clinicians were leaving the practice of emergency medicine or clinical medicine each year during the early phases of COVID. So it seems a bit abstract. The same way lactate might seem abstract in a patient with septic shock, but what it tells us is how dead are we? So it's not just how dead are we, it's how dead are we at a cellular level. So in the same article, there's this table that speaks to a few things. So I want to first draw your attention to the year. Under the year, we are going to be looking at everything from top down. So everything very pre-COVID to everything during COVID at the bottom. And what I want you to then look at is the overall numbers. So this column represents kind of a mean value or an average value of everything in the rest of this table. And if you look at that, you'll see if you go from 2014 to 2019, it's kind of a steady attrition rate of about 5.3 to 5.7. So we emergency clinicians, we take things in the middle load. So let's say it's about 5.6 attrition rate. Then they take a weighted mean. So a mean where they can give it a bit more value. And they find that, okay, well, it's about a 5.4 attrition rate if you look at all the factors and you weight things accordingly. But then if you jump down to mid-COVID or early COVID over here, it's sitting at 8.2%. That is a stark increase of about 2.8% from the weighted mean. So that there was definitely more people leaving clinical practice at that time. So if you look at now the bottom section, and we're going to look at it across, you can see that this was a trend throughout all the fields that they looked at. Yes, the study was limited in how they categorized different regions, genders, and other things, but it gives an idea of where you can see there was higher attrition rates during this time. And what I found very interesting were these last two figures over here on the end. And I mean, if you look at that, it says emergency medicine board certification. What would that mean to us? It would mean if you've got an FChem or not. So are you a specialist in emergency medicine or not? And what was interesting, and this will be very important later in the presentation, that the guys who had specialized, fewer of them left emergency practice than the guys who were practicing on the same level but hadn't specialized. So more people who hadn't specialized, so the 10.6%, had left practice than those who had actually specialized. So just remember that concept for a bit later in the presentation. So if we continue through evidence-based attrition, well, I thought, let's see how far back this goes. We have an idea of pre-COVID and early COVID, so let's see how far back this goes. And if you look at this article, it's just 2007. Some of you on the call might have been, just in junior school then. Some of us might have been progressing through a career. But what it tells us is where the thought process was in Yale School of Medicine at the time. So Yale School of Medicine, they have a little bit of a internal magazine, and this article leaked out about taking the E-load. So what does E-load stand for? So these are different specialities, and the research and the articles I'm presenting are very much biased towards doctors, and unfortunately doctors have a lot more voice in some spaces previously and currently. So unfortunately that's the bias here, but let's work with what we have. So E stands for emergency medicine, R for radiology, O stands for ophthalmology, A for anesthetics, D for dermatology. And the reason why they call this the E-load and not the Silk load, the E-load is all the specialities where there was perceived balance or the perceived work-life balance as a medical professional, as a medical doctor in this space. And so people kind of went with that and became a thing. And I mean, there's a lot more in this article. I'd recommend you go and read it, even just to give you perspective. There's some cool pictures as well. So that was 2007, or the autumn of 2007 to be more specific. Then let's fast forward 6 years. So a whole medical degree at some South African universities, whole medical degree later, you can see that the E kind of fell away. Emergency medicine wasn't really seen as a work-life balance area anymore in some spaces. And then if you look further, you fast forward to then 2021, we are now looking at, well, the impacts of COVID, or 2020, there's impacts of COVID that is affecting emergency physicians or emergency medicine clinicians leaving practice or finding challenges in the US. Then we get to 2023, so it's getting a little bit closer to home, and people are still speaking about COVID and its effect on healthcare workers. And then all of a sudden, you see more articles speaking about it's not just doctors leaving. It's not just us doctors, us guys on the top of the hill. It is also nurses. It's also everyone else. And I mean, if you look at this data also from the same year, 2023, you can see that there was massive loss and massive projected loss of nurses up until 2027. So data in this study found that 100,000 nurses left the workforce at that time, and an expected nearly 900,000, so nearly 1 million, or 1/5, so 20% of the nursing workforce was leaving practice. Something to think about. So nurses, doctors, kind of the two stereotypical roles that kids get taught about in medicine. What about everyone else? There's a lot more on everyone else, but I couldn't really find too much because of the bias of where the voices lie. So, well, why are people leaving? We start to then see from 2024, I'd even say touching 2022, we start to see a lot more articles on the hidden crisis of burnout. I mean, this isn't new in our space. I mean, that's why I'm guessing why Caleb named this coffee and cases, because we're so burnt out that we need coffee. But what I'm saying is that there's a reason why this is happening. And there's triggers that might have reinforced this reason that might have always been there. So I had to share this picture. It comes from that first article I spoke about in the Yale School of Medicine magazine. And as you can see, quite dated. I don't remember 2007 looking like this. But I couldn't help but notice the epitome of emergency medicine sitting in the corner over there. I mean, stationery and phones, that's kind of what goes missing or is needed all the time. So what is Times New Roman font, if anyone remembers that? But let's move on. So why are we leaving? Well, a review of burnout among South African doctors. Again, it's doctors only, but let's look at it for what it is. So pre, during, and post-COVID pandemics. That's giving us a lot of insight. That's giving us a cross-section. And in this study, it tells us quite a bit. So let's look at this. So if I draw your eyes to methods, it's a narrative literature review that they were using to elicit this cross-section of time and see what was happening. And what I liked about this article is they tried to give a definition to burnout. I mean, most of us on this call know that finding a definition for burnout isn't the easiest thing, especially when you're looking for a sick note. But burnout is defined as a syndrome resulting from chronic workplace stress, which has been unsuccessfully managed. I mean, that's one thing. I mean, there's more to this, and we'll be sharing these slides with Caleb to share with you guys. There's a lot more to read here, but that's pretty much the crux of what it is. So they looked at a few factors. So they took all of these different things that they were drawing on, and the best way to understand this picture, I know it looks a bit weird with how they did it, where because you've got the blue over there on the label and also in the column, you'd think that what's written here is what's categorized under there. It's actually not that. These are two different parts of the table. It speaks about demographic factors and lists them there, as well as personal factors and lists them. And all of these, so they look at individual factors contributing to burnout, COVID factors, occupational factors, how this all then leads to burnout, and then the consequences of that. Now, the consequences are quite interesting. And the same thing applies here. There's 3 different columns. But what I found very interesting is even the guys who did the article listed work-life integration last as their reason for what burnout is, which is very interesting. So it's kind of ingrained in our minds. But if we look at the consequences of burnout and we look at the personal, patient, and organizational, so taking it from you as the clinician to its effect on your patient to the effect on the organization you're working for, be it private or public sector, there's a lot of hectic stuff that happens, occupational injuries. And then we take it right across on the diagonal to organizational or healthcare system, and there's malpractice litigation. And then if we look at the patients, we've got poor patient outcomes. None of that's okay. So there's a problem in the system. It's related to burnout, it's related to COVID, but then we also have evidence that says that, all of this mindset existed even before all of that. So it's interesting. We've got a bit of a theme going on here. We know that it existed before. We know that it worsened during COVID. Where are we kind of now? So if we look at more data on this, so why are we leaving? The physician satisfaction and burnout at different stages of their career study was done, and this was done by the Mayo Clinic, and it's quite interesting. Not really specific to our context in some ways, but I'll walk you through it. So if we look at this collection of tables, there's A, B, and C, and A represents the prevalence of burnout among middle career, so not middle-aged. I'm not taking jabs at anyone. Prevalence of burnout amongst middle career physicians compared with early or late career physicians according to sex. Then B is the specialty area, and then C is the practice setting. So where are they working? Private, academic, and then in the American context, they throw in veterans hospitals over there. I don't quite know how to make that fit in our setting, but I'm not going to try. So if we go to career stage, you'll see there you've got early, middle, late. And you've broken up into men and women in this instance. And as you can see, there's kind of a bit of a slope into the middle career, more people leaving, not really too much difference between early and middle. So it's kind of like the guys who join your class in varsity, you started as a class of 200, all of a sudden you whittle down to 60. And that seems to be what's the trend over here, very similar. And very few in late stage are leaving, and more women than men in the way that they viewed the study are leaving in late stage. So if we move it then to career, so primary care, which is us in the emergency medicine space, surgical specialties, internal med and peds, don't know why they put those two together, and then other. So if we looked at primary, so the more orange bar, or the one on the left in all 3 of these different career stages, you can see that same trend persists. It doesn't really deviate, and so then to dip off a lot sooner than in the academic space. And then it speaks to how much more has been invested in the academic space, or as we understand it, state hospitals, we are training clinicians. So it looks at what's the perceived investment there. So that's another seed I want to plant as we start progressing through this. So with their conclusion, physicians face different challenges at different stages. Okay, duh. But middle career is particularly challenging career stage characterized by high work effort, higher prevalence of burnout, and a greater career dissatisfaction regardless of sex, practice setting, and speciality. And then the rest of the stuff speaks about how strategies to improve the work experience of middle career physicians are needed to maintain productivity. That's the first thing they're mentioning. Productivity, minimize turnover. I would have put that one first. So how are you going to keep your staff happier and safer, and then be more productive, and then improve patient care? And actually put that one even before everything else. So very interesting way to set context for thinking here. So another thing is, well, they're not just leaving, we aren't able to enter into the industry. We all know about doctors who aren't able to get jobs in the industry. This applies to nurses and paramedics and every other clinician in our space as well. It's not just doctors. But this is a constraint that we find. So guys can't even enter the system. So now you've got two groups of people who can't get in but need a job, and people who are going out and need a job. And then in the middle, there's this cloud of whatever's happening. So I thought, let's look at it through a little bit of a business lens now as well. So we're doing a little bit of a pivot, going through a business lens. So McKinsey & Company is a consultancy similar to mine, which is also a consultancy. They just happen to be the biggest one in the world. I'm somewhere. And this article was published in September 2024. And it said the physician shortage isn't going anywhere. Okay, interesting. So they're speaking about a shortage that exists, but it's not going to budge. Okay, why? So they did a survey of clinicians, and in this context, again, specifically doctors. And I want to dwell away from that thinking of an us versus them, or segregated groups or siloed groups of clinicians. And how I'm highlighting that is speaking to the point of the voice out there is very unilateral. The voices in spaces like this need to be very inclusive. So if we look at this, physician respondents interested in changing jobs continues to grow, and they're often being approached with other options. So you'll find that these business qualifications like to use graphs to look pretty, and they don't always convey things, but sometimes they convey things really well and look pretty. So let's see how this looks. So if we look on the left, it's physicians who want to change jobs. And if we look at the right, it's the frequency that physicians are being asked to change jobs. So people who want to, on the left, and the other stat on the right is telling us about when other people are saying, hey, do you want to come and do this thing outside of the clinical space? And let's start with the more funny looking graph. So the boxes on the right represent the numerical value. So 9 and 8, you can see that 9 is slightly bigger than 8, 11 is bigger than both of them, and so on. So we kind of have an idea of what the boxes are representing. And this little ghosted block on the top over here, or on the side, says that the top represents that half of the people who they did the survey on said that they are approached every week to leave clinical practice and go into whatever other space. Very interesting. And I mean, there's even a cohort that will ask daily. So if this is half of respondents, and we know it was 18, very close to half, so too short of half of respondents of the survey, this is represented as a percentage. 2% either way on daily and a couple of times a week compared to weekly, which brings up half of them. It's very interesting. So people are being asked to leave. And then we see that there's an upward trend between 2022 and 2023 of people wanting to leave. So the two kind of meet in the middle. People want to leave and people are asking them to leave. So there's an exit plan. So then we look at this graph, which looked at kind of the reasons or what was important in these spaces. And physician respondents report the ability to take time off and find coverage. So what they kind of mean by coverage is people to cover their time. find coverage are the most important factors for improving work flexibility. So more staff, more time off, kind of everyone's dream. So the importance of various factors, if we're looking on the left, the importance of various factors of working hours or schedule flexibility to US physicians, and then they categorize it as two groups. Very important factor. This seems like the tail end of what's called the Net Promoter Score. Those of you who are hospital-based in the private sector, you probably know these types of scores because you get given hell about it. And it's how we improve patient satisfaction. That's the general space it's used. And what they've done here is they flipped it and they said, what is physician satisfaction or workforce satisfaction? And it's usually a rating from 1 to 10. And guys who are sitting kind of 8, 9, 10 are the strong promoters. So they kind of took the tail end of this group. And they said, okay, what's the comparison between, okay, everyone agrees these are important things, but what's the proportion of what is very important to important? And if you look at ability to take time off, well, that's extremely important to people. But then there's a cohort that feels is, just important. And that's interesting. Taking time off, just important. Okay, there's a mindset issue over here. And if we throw back to some of the other literature I showed you guys, there's burnout. Now, there's a mindset of taking time off is important, but it's not very important. Interesting. I'm not going to go through all of these for time's sake, but it highlights quite a few things from pay to time working, time off, etc. Really interesting article to read. I'm happy to share the articles as well, but really interesting to read. So physicians' clinical time is not optimized for patient care that only they can do. Okay, so what does that mean? It's kind of scope of practice questions. And I threw this into a little bit to be a little bit controversial because that's what we are in emergency medicine. And I think that with this, it gives a lot of perspective. So what they did was they said with nearly 20% identified by respondents as delegable tasks. So this task can be done by someone else. And now we have to ask ourselves how much ego is involved here. Because I mean, there's a lot of ego in not just our space, but every space. And also understanding of people's roles and importance across the spectrum of healthcare. When I say across the spectrum, I don't mean there's a better or worse spectrum. I mean there's a spectrum of different specialized professionals where you've got overlap in skill sets, but there are certain skill sets that some groups are trained to do better in some things. And I mean that's potentially another talk and another conversation that's quite deep. But what I wanted to show you guys here is that the perception of delegatable tasks, a proportion of that was said to be able to be delegated to technology. And I mean, that's interesting. It's really interesting. So not just about human professionals, but technologically enabled professionals. Interesting thought. So I'll just leave that there, something to think about. So where are they going, or where are we going? So took the JAMA, which is pretty much apex journal in the health space. So the Journal of the American Medical Association or something like that. I always got it wrong. I might get it wrong now, but if we look at this article, which was in 2024, so last year, job flows into and out of healthcare before and after COVID-19 pandemic. They have this heavy focus on COVID, and yes, it has caused some change. But I mean, we looked at something from 2007. This thought process was already there. People wanting to be comfortable and have normal lives and find it elsewhere, like greener pastures mentality. So, well, what I liked about this article is how they looked at all of this. So the table represents 3 different years. They see 2019 as pre-COVID, they see 2020 as height of COVID, and they see 2021 as sort of like the petering off mid to end phase of COVID, which is why they looked at this. And then they represent each quarter, so 3-month batches in each year, and what was the exit rate from the health sector in those periods. I'm not going to speak about the box and whisker thingies at the top. That's more further leading and deeper leading. But what's most important is looking at a trend. But something else I want to point out to you guys is this dotted line isn't just me forgetting to take markers out of a screenshot. What that actually is is it shows parameters for 2018 exit rates. Okay, so what does that mean? Like, why is that significant? We already have 2019 to 2021. Well, if 2019 is before COVID, the reason they're giving perspective of 2018 is, okay, well, this is before COVID. So something that represents where more closely to where the world might have been before we started heading into this roller coaster ride of COVID. So if we look at that, it represents that the exit rates over here, healthcare worker exit rate percentage points, so these are percentages of healthcare workers leaving. 2018, it was kind of sitting on a mean of just under 6. And if we go back to all of those other articles we looked at, kind of confirms what's happening here. And this was a cohort study. So we've gone through different types of studies already. So we've had literature review, we've had a letter to the editor, and now we're looking at a cohort study that I think, if I remember correctly with this article, they looked at census data and extrapolated this information from the census data. So number one, we've got two different research forms that confirm each other that between 5 and 6 is a good mean to use. It's confirmed with 2018. You can kind of see the trend persists in 2019 of around about 5.6, 5.7. which is the number we landed on earlier. But then COVID happens and bam, first quarter. So we all remember March 2020. I was at a music festival at the time and I had swine flu, diagnosed swine flu. So you can imagine what that would have caused in that setting when I got home from that festival. But we can see there's massive attrition or increase in attrition in that time. Be it driven due to fear, due to whatever people were thinking, what we were all thinking at that time. Massive peak, kind of tapers down, peaks up again, and kind of runs through. So essentially, it doesn't tell us too much besides it's all more than 2018 and it's all more than 2019. Okay, so it's more than what we've established as the previous trend. So then, if we look at the adjusted mean exit rates for healthcare sector over time by exit type, I would love to give you guys more granular detail on this and drill down and say, these guys left to go and open a spaza shop. These guys left to go and open a shebeen. These guys left to go and open a business of some other form. I'd love to give that granular detail, but I can't. And the reason is people have been looking at it through a very generalized lens. So they've looked at it through two lenses. Number one, are people leaving to nothing? So no plan B. And I'm talking about plan B as in no job plan and no form of or some form of employment outside of the health sector. So no work or work that's not healthcare driven. Okay. And then again, the dotted lines come in to show where this was sitting for 2018. So I'm just going to let us focus in on 2020 now. And if we look at 2020, so the darker squares or the darker bars show us exit to non-healthcare sector. Okay, boom. It's not really more than where the trend was, and it's pretty much still under the trend line for 2018. And then exiting to having no plan B, no job, nothing, nada. You're sitting at home. And this is an American context, so it's slightly different to ours, slightly by a few exchange rates of nearly 20 rand to the dollar. But what you can see is that there's a massive exodus to unemployment, or what they call non-employment over here, in the beginning of COVID. And if we just fast forward a whole year and look at the 2021 graphs, you can see that there was a steady but sure increase throughout 2021, and I would assume persists into now, of exiting into non-healthcare spaces. And not just is there an exit into non-healthcare spaces, it is a lot more than what was happening in 2018 or anything else. Significantly than the little orange line. And then even look at the non-employment leavers. That's even higher than 28. So people are just leaving, like indiscriminately at this point. So then I looked at another article, which was a cross-sectional study, which was tracking the turnover among healthcare workers during COVID-19 pandemic. This is a 2022 article, so a slightly older article, also from the JAMA cohort of journals. So they've got some sub-journals and columns that are really interesting to read. And what it shows us is that pre-period, so that's the 2019 or 2020 periods that we're looking here, post-period, which is height of COVID, and post-period 2, we see that there's another study that confirms that everyone was kind of leaving during COVID. Doesn't really tell us anything special, but that everyone was leaving during COVID. So how do you leave? So how do you hit eject? Those of you who know me, I kind of say that I hit eject when I moved out of clinical medicine. For me, it was a lot more about where I actually wanted to be. I started getting worried when I found green patients irritating. That's when I got worried. Because when I was in clinical medicine, I just wanted to see patients and do procedures and things. But when I started finding green patients irritating or boring, because I mean, you came into this field to help these people, regardless of why they're pitching up at your ED or wherever you might be. So low acuity patients, when I started finding that to be an irritation, I started asking questions. There's a problem here. This isn't what I signed up for, and definitely isn't what my patients signed up for. So how do you leave? Well, these are some prominent figures in the South African healthcare space. On the left is Dr. Vuyani Mhlomi. I worked with him on the executive team at Kula Medical. He is the founder and CEO at Kula Medical. And on the right is Dr. Chris Matthew. He's in the netcare space, both in tech spaces. Both were at Oxford. I think both had Rhodes scholarships. And I think both even have MBAs. I know Vuyani does. Not too sure about Chris. I can't remember too well. But they essentially moved from clinical to academic to corporate. And in their instance, their corporate route was very much tech. So two interesting people to go and check out. There's interviews of them everywhere. So they're kind of more famous and easy to find resources on how did they leave, how was their journey. Okay. Then there's the clinical to politics. It's not just South Africa that does this. It gets done everywhere. This is Dr. Alan Motsoaledi's second time or third time. I don't know. I don't really follow politics too deeply, but also a doctor who has become the Minister of Health of the country. Then people moving from clinical to arts and entertainment. There's Riyad Musa. He left clinical medicine and started becoming a stand-up comedian, and that's how he generated revenue for himself. Or you can do things the other way, which is clinical to corporate to whatever you want to do. So there's a lot of things to think about in what is actually limiting us as emergency professionals in our transitions. How are we transitioning? Well, I can't tell you. There's not one way. There's lots of ways to transition. And essentially, it's what fits you best. And I think that's where the discussions come in very handy. But there's a few concepts I also want to leave with you before we head into the discussion. Caleb, how are we doing for time?
You're good, Luke.
Okay, cool. So should you do it or not? So one of the ways that I like looking at it is the sunk cost fallacy. And I just realized now I didn't include a picture of a really awesome book where you can learn about these different forms of fallacy and thought fallacy. It's called Thinking Fast and Slow. The author's name I can never remember, but I'll remember it if I see it. So what is that? Thank you, Caleb. Thank you very much. So the sunk cost fallacy. So now you guys know why Caleb and I get on well. We're good leaders as well, not just coffee and emergency medicine. So the sunk cost fallacy is the phenomenon whereby a person is reluctant to abandon a strategy or course of action because they've invested heavily in it, even when it is clear that abandonment would be more beneficial. And the example that Google gives over here is the sunk cost fallacy creeps into a lot of major financial decisions. I can assure you it's not just in finance. So, yeah, speaking of finance, it speaks about costs that have already been incurred and cannot be recovered. Okay, interesting. So I just want to play you guys this 2.5-minute video. I think let's watch it on YouTube instead. When it decides to play along, just give it a second. Can you guys hear the sound? Yes or no? Think, Caleb?
Not yet.
Can't hear any sound.
No.
And can you hear the sound? Caleb?
Sound on the video, right?
Yeah, sound on the video.
I don't know. It doesn't seem to be playing right now.
Okay, well, it's paused now, but when it plays, do you hear the audio?
Let's try it again.
I would like to...
Yes.
Okay, happiness. Cool, let's go ahead.
present a simple but very important idea, the sunk cost fallacy. It's the dangerous belief that you should stick with something just because you've invested something in it. So imagine you're sitting at home watching a movie and it turns out the movie is really bad. So what do? Well, you stop, you watch a different movie or do something else. But what if you're in the cinema and you paid 15 euros for the ticket? Well, then you might think, okay, I've paid money for that, so somehow I have to see it through. But why? Because you see, the 15 euros are already gone. That's sunk cost. That should actually not influence your decision anymore. What you can do is optimize your current situation. And if the movie makes you have a bad time, then you should just leave. Or imagine your car breaks down and just last week you had it repaired for 2,000 euros and the mechanic says, well, yeah, it can be repaired again, but actually it's not worth it. What do? Well, you may feel, I've just spent a lot of money on that car. I can't throw it away now. But again, it's sunk cost. What's gone is gone. You have to optimize your current situation, not throw good money after bad. And I think that this sunk cost fallacy is also the reason why so many people tend to stick to ideas which are clearly wrong. If you believe that there's a huge conspiracy going on, that the government is trying to kill us all with vaccines, or that aliens secretly control the earth, then you probably spent hundreds of hours on that theory. And maybe you've even paid a lot of money for questionable books, and maybe you've lost some friends who don't want to listen to your nonsense anymore. So clearly, you've invested a lot, and so it's very hard to let go of these ideas. But again, sunk cost. What's gone is gone. You have to optimize your current situation. And sometimes this means changing your mind. And that's hard, but it's important. And that's why we all should make it as easy as possible for people to change their mind. When somebody used to believe in something stupid and then changes their mind, we should not ridicule them as ex-conspiracy theorists, but we should applaud them. Because changing one's mind is progress.
There we go. So changing one's mind is progress. And I kind of want to highlight that because in any medicine, might just be my experience, but we tend to think in silos and treat each other in silos as well. And when people change their mind, we always view corporate as the big villain, right? Because they kind of pay our checks. But when you get to the other side, you kind of see it's a lot of the same. Just, I don't want to use the phrase because we're in a public forum, but same something, different day, which is a phrase that we use quite often in emergency medicine. But I'll challenge that mindset. So I don't know if you guys are as old as me. I won't say Caleb as well. I don't want to give Caleb's age away. But you might remember a movie called Bubble Boy, and it was based on this kid, this really, really strong named David Vetter. And David Vetter lived in a literal bubble his whole life. He had a very rare autoimmune disease. I can't quite remember which one it was right now, but couldn't be exposed to any bugs or anything hectic. And unfortunately, he passed away, but he spent his whole life in a bubble, entire life in a bubble. All he knows is having cling wrap around him with pipes, tubes, and things. You can even see in the background over there, his teddy bear is busy chilling with him in the bubble. And Bubble Boy the movie was inspired by his story, took a different twist. And if I remember correctly, he didn't actually have a reason to wear the bubble, and it was just his family trying to control him or something to that effect, typical early 2000s, late 90s movie themes. But he was stuck in a bubble. And there's a point at the movie where he's looking at the snow, and he kind of has this come Jesus moment, or this paradigm shift that happens where he's like, damn, that's me in a bubble. But life is an adventure, and don't blow it is quite interesting in that context, because changing your path, as we've just learned, is not falling for the sunk cost fallacy. It's pursuing your adventure in life. It's not living in a bubble. It's trying to pursue other things and seeing other people, their ways of thinking and living differently. And you kind of see that the world is a bit different when you jump out of the emergency medicine bubble or the medicine bubble. We kind of believe that that's the world. I'm not saying that's all of us, but I do think it's a lot of us. And I just want to leave things there with that thought before we go into discussion. And thank you very, very much. Caleb, over to you.
Awesome. Thanks, Luke. I think we'll open up to any questions, any thoughts. Waldo, go ahead.
Hi. Morning, everybody. Morning, Luke. Thank you so much for a great presentation. Lots of interesting stuff to ponder on. I apologize. I missed the first 5 minutes. So if my question has already been answered, just let me know. A lot of the data you speak about is obviously American-based and then more so doctor-based. How much of it is, in your opinion, generalizable to the South African context? And then furthermore, is it possible to generalize that a bit further to us in the paramedic space?
Thanks, Waldo. I just want to make sure you finished your question.
Yes, my audio is okay.
Yeah, no. I think very important question. Some of which was covered, but let's delve into that. Let's put the foundation down again. So the data is very much skewed, as you said, to the space. And that is because the voice of research in many of these spaces so happens to be doctors. And it's something that I'm not a fan of. I'm an anarchist. I'm not going to burn people's houses down, but when it comes to hierarchical placements, even in the corporate space. And I feel that to answer your question, this can be generalizable in the healthcare space. And we looked at two different populations, doctors and nurses, which are the two healthcare roles that we get told about as kids. And I mean, everyone else just drives an ambulance in everyone else's mind, which I find as being a very irritating mindset. But I do think that it can be generalized across, because we've seen the same we've seen the same with nurses, we've seen the same with doctors, and I'm very certain, had I been more diligent and drilled down a bit deeper, I could have even found some information in the paramedic space, even though it's a little to find. But then to the other half of your question about in the South African context, definitely in the South African context. And one of the other drivers is clinicians, broad terms, who can't be employed, and clinicians exiting for whatever reason. So it's definitely generalizable. I've seen a lot of paramedics into the Caleb is one of them. Caleb and Tash and the team are a group who've done this, but are still 1 foot in. So I do think it's generalizable. Did I answer your question, Waldo?
Yes, you did. Thank you so much. And I just want to make a comment. One of the things you said, really insightful, and I just want to repeat it for everybody. The voices out there are very unilateral, and the voices in spaces like this should be inclusive. That's one of the reasons we started this Coffee and Cases. And it's one of the things that underpins almost everything Caleb does. So thank you for that. I think it hits the nail on the head.
Perfect. Thanks so much, Waldo.
I see there's a comment from Cindy who just speaks about in EMS, there's a sense of always needing drama to have a reason for being. And once you extract yourself from the environment or realize you're okay without the drama, then everything just seems to be better. And I think that's probably relatable not just to EMS, but probably to the whole emergency medicine space. I don't know if you have any comments about that.
Yeah, not to be someone who wants to take over the conversation, because I paused for a bit to give other people a chance to talk as well, because I've been blabbing. But I do think that's true. Like, I mean, if I think about the space I found myself in when I was in emergency medicine, so for close on the better part of a decade, I think it was about 6 years in private healthcare emergency medicine space. A lot of that was spent as a manager of a unit, and then you're dealing with the business aspects and the clinical aspects and all the politics that lose everything in between. And when I removed myself from the drama and the different mentalities that are stereotypical for our space, I tended to see the world a lot differently. And I think it's an exercise that we actually need to be doing as just people in general. Whatever space you're in, try and find a space that helps you view the world differently.
Awesome. Yeah, I think that's a really good point. I see there's another hand up. Mike, go ahead.
Hi, morning, everybody. Sorry, I logged in a little bit late, so I missed a bit of the first part of the presentation. But for what it's worth, just from an ad hoc survey of people that I've interacted with over the many years in EMS, I would say that some people are transitioning out not because they necessarily want to, but because sometimes they feel they don't have a choice because of burnout and other challenges within the profession, because the needs of the practitioner are not met through various corporate structures. So that's just my thumbsuck overview of all the people that I've met who've left the profession and why they left. where they went to and their reasons for where they ended up would be a topic for another debate, because sometimes people don't always end up where they really want to, but they don't have any other option than but to leave because of the space where they are in, head and corporate space. So myself, I left for numerous reasons of full-time practice many years ago, and had moved into the business field for the last 20 years, but still dabbling heavily in the medical aspect. But my reasons for leaving were, as I've articulated with most of the people that I've spoken to, which is from a stress, burnout, poor upper management, corporate structure, and those sorts of toxic environments.
Yeah, Mike, I think you raise an excellent point, and the research shared in the presentation does definitely confirm that. But I just want to frame things a bit differently, just to ensure that we aren't throwing eggs. And what I mean by that is, we tend in our space to think in silos and have us versus them mentalities of things. Yes, more often than not, there is lack of insight from corporate structures into what's happening in the more clinical, or on the load, or in the unit, or on the floor space. But then we also need to ask ourselves, how much communication have we done there? And I know that in many spaces we have communicated up into corporate, but I want us to steer from potential egg throwing. Not saying that was what you were doing in your comments, but I just want to speak to the general audience on the call, because a lot of burnout, we have to ask ourselves, how much have we also allowed? And let me tell you why I want to speak on that topic. Burnout has put me in the ICU twice in my career. Once as a emergency doctor on the floor, and once in corporate. Fair enough, corporate in emergency medicine, but neither here nor there. But once was with, they thought I was having a stroke. I had a stroke mimic, which was a hemiplegic migraine. The second time was I had too much coffee and ended up with a Prinzmetal angina because I was so burnt out I could only function on about 7 espressos a day. So we also have to ask ourselves, and this is to add to what you've said, Mike, because what you've said is extremely important. This is to add and not to detract from what you've said, is that we also need to ask ourselves, how much have we allowed? And we need to be informed of that, because there's a very much a worker bee mentality amongst us in emergency medicine, and it's something that can be dangerous. And I want to leave that there and allow for more conversation around that as well.
Oh, I think some really amazing perspectives, and just sort of thinking back to some of the times when I've burnt out, a lot of them are not really related to the work so much as the red tape that sort of goes with the politics of the work. And then sometimes also just not having the values of what I'm doing line up with the values that are really important to me. And so I think the point that you've made of what do we allow is also a big part of I think why people in the space do burn out, is because we do have that idea of must perform against all odds, and humans, we're more than human, right? We're superhuman. We're in emergency medicine.
If I can just comment again, I hear what you're saying, Caleb, and as well, that we do sometimes put an unnecessary kind of mantle over our own shoulders based around the emergency medicine dynamic. And that is true, and that has been true for myself as well in and out of the profession. And not even when I'm in the profession, even when we're doing normal work as well. But burnout is real no matter what job sector we're in. But I think there are significant triggers and stresses within our profession, which the debate for this topic isn't really focused around that. But that would be another interesting debate, to look at those stresses and triggers in terms of how vicarious trauma building up, how compassion fatigue building up, and all of those triggers, which then pushes one into sometimes poor decision making across the board in a number of areas, be it either in terms of why we leave or why we stay, or then also in terms of sometimes patient care and interacting with other people around us.
I think that's excellent context that you've added there, Mike, because burnout is real, really real, and it definitely is something that is not just limited to our sector. Waldo, sorry, Caleb, to take the reins on your behalf. Waldo, I see your hands up.
Please go ahead.
What do you feel can organizations do? I mean, obviously everyone here has been part of organizations and has a pretty decent understanding of the organizations in which they work. But what do you feel are some low-hanging fruit things that organizations can do to help retain staff? Because personally, I don't really like patient satisfaction surveys. I think they're quite skewed, and I think they possibly look at the wrong thing and bring undue stress to providers. But what is some of the like low-hanging fruit to improve morale and to try and prevent burnout? Because we know, oh, let's buy everybody pizza. It's not the answer. Do you have anything that tips that we could use, people could try and bring into their organizations?
Yeah, sure. Well, I think that's a brilliant point. I mean, everyone likes and hates a pizza party at the same time. I just want to go to your point on patient satisfaction surveys. I think that we need to have balanced mindsets. I'm not saying that you don't, but I think that, again, trying to speak to the audience, we need to have a balanced mindset on how to view things like that, because that's a form of criticism that's potentially positive or negative, coming from a perspective of a cohort of people that perhaps don't have all the perspective, but it's still their voice in how they're experiencing things. So what I tried to, so I'm going to start with the patient survey perspectives, and I hear what you're saying on how it can potentially be detrimental to morale, etc. And then I'm going to speak to other strategies that I've implemented in corporate sector to try and manage burnout and fatigue in my teams. So let's start with the patient satisfaction survey. When I started managing the emergency unit at Kingsley, so Life Healthcare uses what's called the PXM score, patient experience score. I don't know where the X comes from, I don't know where the M comes from, but that's what it is. And what it used to do was really demoralize the team. And then I realized the team actually doesn't understand what's being measured in this metric. They just get this number, they get told it's pretty much FUBAR, and then they go on with life. It gets treated like a lactate that no one understands. So what I then did was firstly, I educated my team about what was being looked at. And when I say my team, I wasn't just sitting with my team of doctors, no. I sat with my team, which is everyone who's playing a role in the emergency unit, from unit manager to receptionist. And we all sat together on a regular basis, educated them about these things. And once more insight was gained by us as to what this is measuring, we then learned two things. Number one, how this influences patient expectation, but most importantly, patient outcomes. And then also how it affected our morale. It then became, we almost gamified it. It became a game. During the time at every single emergency unit I managed, the PXM score, because of that approach, was never less than 90%. Never. We were always in either number one or top 3 in the country from having that mindset. And when I say we were top 3 in the country, it's because I moved from St. George's to Kingsley, and then Kingsley was number 1 and St. George's was number 2. But the reason for that mindset is we sometimes see criticism and we tend to take it harshly in our space. I don't know why. And this is speaking from personal experience, me taking criticism harshly from wherever it's coming from. And that's one aspect, taking criticism, learning how to use it and learning how to implement it in the positive. The other voice it gave us is to say to the guys who were drawing it up, who we initially thought, oh, these are a bunch of MBAs who put the score together. Actually, it's clinicians who actually worked on the floor, who actually saw these things and perhaps are a little bit removed and don't have direct line of sight, but can improve these scores by getting our perspective. So we learned how to have an effective voice and not just a whiny voice. Not saying that anyone here is whiny, but speaking about me when I was reporting this to the corporates at that time. So that's one thing. The other thing is there's a really interesting article, quite a few interesting articles from McKinsey. I quote McKinsey a lot, but there are other consultancies and research bodies that can give you the same information. But McKinsey looked at a few things. It put people on a scale of how much they want to leave or stay. And then on that scale of leave or stay, it looked at people who were double dipping. Double dipping means you're not really happy with this job, so you're kind of doing a second job for either financial or cultural or whatever reasons. And it looked at how to specifically approach these different individuals in your team to either get them to stay, or if they are that far gone, get them to leave so that they're not toxic to the rest of your team. Because sometimes you can just have people in your team who are downright toxic. And they're just miserable. Not saying that is always the case, and we need to be careful not to blanket term things. But sometimes you get people who are just toxic for what you're trying to actually build and don't need to be in that organization. So it looks at that, so the quitters and all of this, and also looks at quiet quitter trends, which is another thing that's covered in COVID research. And what I did was I looked at aspects of from that and applied it to my team. So when I was at Culo, I had a very marginalized group of clinicians known as clinical associates. If you know what's a clinical associate, I applaud you. If you don't, please go read it up. Otherwise, we're going to have a conversation around a different type of coffee. But clinical associates are mid-level healthcare practitioners that kind of fall in between a registered nurse and a doctor. And they kind of get overshadowed in the healthcare space in hospital, and similar to our paramedics perhaps experience same out of hospital, entering hospital. And I had a team of these clinical associates who, number one, felt ostracized. Number two, didn't have a sense of community. Number three, didn't understand how to actually do a roster and didn't know how to find work-life balance, just accepted what was put in front of them by themselves, not necessarily the organization. And so a lot of the strategies that I took, Waldo, were to educate the team. So you'll see there's a persistent theme here, educating team on things. So educating the team on what work-life balance is, what burnout actually is, and what a balanced roster looks like, and why a roster needs to fulfill certain things for the company to stay afloat so that we can pay salaries. But at the same time, we can't have people burning out and not functional. So it's a really difficult balance to strike. And sometimes 1 month it will work out better for some people, and another month it might work out better for others. But the theme is to have consistency and fairness. And those are the strong themes that need to apply in those spaces. And what we noticed is once that strategy was implemented, we did a net promoter score, an employee net promoter score on how these guys are feeling in the company. So when I joined, they felt a certain way. So before I even had any influence on the company, they felt a certain way. Let's say their score was 20 out of 50. After implementing that strategy, it ballooned all the way to 48. And I think, if I remember correctly, 48 falls in the territory of excellent on a net promoter score, because a net promoter goes minus 100 either way, minus 100 and plus 100. So that was one. Then I also looked at the remuneration structures and career pathway structures in place. Remuneration structures were pretty much, I don't want to denigrate the company I've left, but there wasn't quite a formal structure in place into how people were remunerated, how overtime was approached, and all of these things, where people are investing part of their life and then needing some sort of reimbursement for it. So I put that in place. And then another aspect was looking at career growth and development. So I looked at CAs. I'm like, there isn't anywhere else in the world where CAs actually have a clear career path. So I built one. And I put in a path for, a lead clinical associate, so for guys to step up, and then told them about where the rest of the pathway can end up, and how even one day, if they pursue this pathway, they can end up on my level as an executive in the company. And that even improved morale in the team. So a lot of this are business-oriented strategies that I implemented in a clinical context that brought a lot of positivity in a clinical context. There's a lot more I can say on this, but I don't want to hog the conversation. Caleb, Waldo?
Thank you so much. I think that answers my question pretty well. I know Caleb popped off for a second. I don't know if he's back yet.
I am back.
Cool.
I don't know if there's any other thoughts or questions, any other hands that are waiting to go up. It looks like it's pretty quiet. Just some thank yous to Luke. So then I'm going to take the opportunity just to say thank you to Luke for the awesome presentation and starting a really cool conversation. I think a conversation that's going to probably need to carry on over a few weeks and months to kind of come to an idea in the South African space. In the absence of having systems in place that are super supportive and ways to help our people, I'm going to ask that when you scan the QR code and go to the register, you'll also notice that there is a link where you can join to become either a mentor or to join our mentee program. And if you find yourself with some expertise or a little bit of time and some experience to share, we'd love to have you as a mentor. There are no prerequisites except interest and willing to engage with the system the way that we would like you to. And if you're looking for any kind of assistance in terms of mentorship, please go along and submit your details under the mentee program so that we can match you with somebody who's got interests in similar areas to you. Other than that, the word for today has been loaded in the chat. It is what's next. So please don't forget to put that in as your topic or as the word of the day. And yeah, thank you very much, Luke, for your awesome presentation.
Thanks, Caleb. Thanks, everyone. And happy I could have added some insight and stirred the pot a bit. Thank you very much.
Awesome. Thank you, everybody. Have a fantastic day.
Cheers, everyone. Thank you.
Luke, are you still here? There is a question. I think if you have capacity and time, if
Sure.
you'd be keen to maybe sign up as a mentor, if you are interested in it. There are some
Sure.
people who are looking to have some direct conversations with you, which I think would be quite cool.
Sure. I think I'll just need my hand held to how to do that, but happy to do that.
No worries. We can do that.
Cool. Thanks.
Awesome. Thank you, everybody.
You can,